Hello to all, I am Vishnu. So we'll start a new series today. So this is regarding drug mnemonics. I actually referred some books. There are some literally authentic books in pharmacology reviews, which actually, they have made their own mnemonics. And some mnemonics I have made of my own as well. So I just thought that, I'll share that with you. So this is going to be a long presentation, which will be divided into individual segments. We'll have different parts. So today I'll be talking on part 1. So this will be easy for you to remember some things. Obviously, in mnemonics, we can't cover a lot of things. Some very easy things only we can cover. The remaining details, in the pharmacology perspective or, therapeutics perspective, you should know by reading standard books or something like that. This is just to help you to remember some things in the easy way possible. So why mnemonics? Because pharmacology is one of the most difficult subjects in medical science because, so many medicines are approved every year by the CDSCO or the US FDA or different regulatory agencies. And existing drugs itself, we don't remember much. So what will we do when newer drugs are also coming? At the same time, it is our responsibility to know about everything. So definitely it is difficult. Along with newer drugs that get approved each year, remembering the older ones is obviously a very big obstacle in the path of smooth memory. Impediment means obstacle. So that is why I just thought of easy to remember mnemonics, which helps in easy interpretation. And it is also, very catchy. So it is good to memorize. And obviously it is good for smart work. Like, for example, you want to do combined study with someone, or you want to discuss something with someone, mnemonics may help you in the process. Definitely, you can make your own mnemonics also, but please make sure that you don't get addicted to making mnemonics, because if you start making mnemonics for literally everything, then there is a tendency that you may forget which mnemonic was for which. So, mnemonics to a limit is good. So I hope that this presentation will be of service to you in easy remembrance of some systems, some side effects of medicines, and some good catch points which may help your practical knowledge aspirations. So let's come to general pharmacology. So let's come to drugs with high first-pass metabolism. So this kind of molecules, the problem is that if any molecule undergoes high first-pass metabolism, the plasma drug concentration of such medicines will be very less. And that is why if you take them orally, these medicines will not be very effective for you as much as you require them to. And that is why these are available in various other formulations other than oral. So to remember the name of drugs that undergo first-pass metabolism, remember the code. Nitrates have large pre-systemic metabolism. So nitrate stands for nitrates. So that is why you know that nitrates are used for angina pectoris. So to avoid the chest pain, because it's a very powerful vasodilator. And that is why when you suddenly have an acute angina attack, nitrates are given sublingually, because when you are taking any medicine sublingually, it escapes the first pass metabolism. Hydrocortisone is a steroid, you know very well. So hydrocortisone is one of the least potent steroids. So it is usually given parenterally. Lignocaine is another agent which undergoes large pre-systemic metabolism. Then pre stands for propranolol. Please remember, propranolol is an antihypertensive and it is a non-selective beta blocker. Non-selective beta blocker means it blocks all the three receptors, beta 1, beta 2, and beta 3. Let me tell you some interesting things about propranolol. First, we have to understand which are the different beta receptors. There are 3 beta receptors. beta 1, beta 2, and beta 3. Beta 1 receptors are found in the blood vessels, and beta 1 receptors usually cause increased heart rate. So propranolol, when it blocks beta 1 receptors, it causes bradycardia. Beta 1 receptors are also found in the juxtaglomerular cells of the kidney, from where the molecule renin is released, and as a result of which the RAS pathway, renin, angiotensin, aldosterone system pathway starts. Propranolol blocks that area also. So obviously that is good for hypertension because the last product of RAS pathway is aldosterone, and aldosterone increases sodium and it also causes fluid retention, which is not good for hypertension. Beta 2 receptors are usually found in the lungs, in the bronchial system, in the pulmonary system. So they usually cause bronchodilation. That is why beta 2 agonist, for example, salbutamol, etc., terbutalin, etc., they are used in the treatment of asthma and COPD. So propranolol is a beta 2 blocker because it is non-selective in nature. So as a result of which it can cause bronchospasm as a side effect. And that is why non-selective beta blockers are contraindicated in asthma and COPD. Beta 2 receptors also cause vasodilation. Beta 1 receptors cause vasoconstriction. Beta 2 receptors cause vasodilation. So if propranolol is a non-selective beta blocker, it will block the beta 2 receptor, which can cause vasoconstriction. So that is why propranolol is not a very good agent in the treatment of hypertension. Because on one side it is blocking beta 1 receptor, and on the other side it is blocking beta 2 as well. Beta 2 receptors also have some other functions. For example, it stimulates gluconeogenesis. Gluco means glucose, neo means new, genesis means birth. That means it increases the formation of glucose. And it also stimulates glycogenolysis, glycogen breakdown. So glycogen, when it breaks down, you know, in biochemistry, the last product is glucose. So to speak in precise, beta 2 receptors increase blood glucose level. And if propranolol is blocking that, it will cause hypoglycemia. Beta 3 receptors are usually found in adipose tissue. Adipose tissue, there is an enzyme called lipase, and this actually helps in increasing the good cholesterol and reducing the bad cholesterol. Propranolol will block the beta 3 receptors. So the opposite can happen. Bad cholesterol might increase and good cholesterol might reduce. So as a result of which, non-selective beta blockers should not be used in patients who are having coronary artery disease or dyslipidemia. Since propranolol undergoes high first-pass metabolism, this is a very good agent in the treatment of portal hypertension associated with liver cirrhosis. So if you look at the treatment of liver cirrhosis has a lot of complications. One complication is called ascites. Another complication is called portal hypertension. In that condition, we usually give propranolol or nadolol. Why propranolol is given? See, this first pass metabolism usually happens through liver. So in liver cirrhosis, the liver itself is damaged. So in that condition, propranolol will retain its plasma drug concentration much better. And that is why in such conditions, if you are having portal hypertension, propranolol is a very good agent. So these are some interesting things about propranolol that I thought that I will tell you. And propranolol, you know very well, it crosses the blood-brain barrier also. So that is why it is good for stage fright or stage anxiety related issues. We can take propranolol for that. Next, we come to salbutamol. Salbutamol, you know very well that it is a short-acting beta 2 agonist. So it is a bronchodilator, which is good for asthma and acute COPD. Because acute COPD, why I said is because it is a short-acting beta-2 agonist. So short-acting means the onset of action will be rapid, but the duration of action will be short. So it is good. And this also undergoes high first-pass metabolism. And you know very well that salbutamol is not available in tablet form. We usually take it as a meter dose inhaler or nebulization form. And then we come to morphine. So morphine, you know very well, it is a very powerful opioid. It is used as a painkiller in very, very severe pain. Like for example, if you are suffering from cancer pain or any kind of very severe pain which is not responding to standard painkillers, then we go to opioids. The morphine, you know very well, it is an opioid, so it has its own range of side effects. It's a very powerful CNS depressant. It can cause respiratory depression if you are overdosing on that. And definitely it acts on kappa receptors in the stomach, so which can lead to constipation. Now let's come to the significance of protein binding. So you know very well in biopharmaceutics, we know about absorption, distribution, metabolism, and excretion. So protein binding comes in distribution. So to remember the importance of protein binding of drug, remember the code DDDD, or you can say it as 4D. So the first D is called duration of action. So the drugs which are having high plasma protein binding, they are usually long acting in nature. I'll tell you the reason why. For example, you are in a particular house where you are very comfortable to stay. So if somebody asks you to leave that house and go somewhere else, you will not do that easily because you are very comfortable living in that house. You are attached to that house or at that place. Similarly, when drugs are having high plasma protein binding, they are very much attached to it. So getting them eliminated from the body is very difficult. And that is why if you have studied toxicology, you will always remember that any molecule or any toxin which has a high plasma protein binding, you cannot eliminate it through dialysis. I will come to a mnemonic on that later. So please remember this. If any molecule has a high plasma protein binding, especially greater than 70 to 75%, if that molecule has caused toxicity in your body, you cannot get it eliminated through dialysis. We'll come to the next D, that is called distribution. Drugs with high plasma protein binding, they usually stay in plasma, so the distribution will be low because they are having much more affinity to the plasma, so they prefer staying there. Let's come to the displacement. If two drugs are used together which are having high plasma protein binding, one drug can displace the other. So this is called displacement drug interaction. So a high plasma protein drug can displace another high plasma protein binding drug. And the last is dialysis. As I said before, drugs with high plasma protein binding, they cannot be removed by dialysis. So just as I said before, if any drug is having very high plasma protein binding, you cannot eliminate it through dialysis. So to remember that code, the code is avoid dialysis. A stands for amphetamines. Amphetamines are very powerful CNS stimulants. They increase the level of dopamine in the body. V stands for verapamil. Verapamil is a calcium channel blocker, which is usually used in arrhythmia conditions. O stands for organophosphates. Organophosphates, you know very well, they are usually pesticides. So we have a lot of organophosphates which are used as insecticides and pesticides. So this you can study in toxicology. So in toxicology also, if you have ingested an organophosphate, dialysis cannot be used upon you. And then we have opioids, as I said before. Opioids, poisoning also, dialysis is ineffective. I stands for imipramine. Imipramine is a tricyclic antidepressant. D stands for digitalis. You can say digoxin also. So that is why if you are having digoxin toxicity, we cannot use dialysis. And the D of dialysis stands for diazepam, which is a very powerful benzodiazepine. So if you are having diazepam poisoning, dialysis cannot be used. So this is one mnemonic. Now let's come to the name of prodrugs. To remember the names of prodrugs, remember the code. All prefer doing MD in clinical subjects. A stands for ACE inhibitors. Remember, all ACE inhibitors are prodrugs except captopril and lisinopril. Captopril and lisinopril are not prodrugs. So first of all, let us understand what prodrug means. Prodrug means it is an inactive molecule. When it enters into the body and undergoes metabolism, the active metabolite gets released, and that active metabolite shows its pharmacological activity. So all ACE inhibitors are prodrug in nature except captopril and lisinopril. P stands for prednisone, which is a steroid, proguanil, which is an anti-malarial, and proton pump inhibitors. Doing stands for dipivefrin. So dipivefrin also is a prodrug. M stands for mercaptopurin. Mercaptopurin is an anti-cancer agent. Methyl dopa. Methyl dopa is a central sympatholytic. Actually, it actually was the first-line agent for hypertension in pregnancy, but now it has been replaced by labetalol. And minoxidil, you know very well, it was actually an antihypertensive, but its side effect came in the form of hair growth. So that is why minoxidil is not used as an antihypertensive now. It is used in shampoos for people who are having hair loss. Another D stands for dopamine precursor, that is levodopa. So levodopa is actually a prodrug. I stands for irinotecan. Irinotecan, topotecan, these are actually anti-cancers. And INH stands for isoniazid. Isoniazid, you know very well. It is an anti-tubercular agent. And isoniazid has a lot of significant, interesting things, like it is hepatotoxic in nature, and also it causes pyridoxine deficiency. That is why whenever you take isoniazid, pyridoxine you should be supplemented on, or you should take pyridoxine also. Because if you are having pyridoxine deficiency, three things can happen. Number one, you can suffer from peripheral neuropathy. Number two, if you are having too much of pyridoxine deficiency, you can end up in seizures. And number three, if you are having pyridoxine deficiency, you can have mood changes, like you can be very irritable, you can be aggressive, all this kind of things can happen. Then we come to clinical C. So C stands for cyclophosphamide, which is a anti-cancer agent, alkylating agent. You know the speciality of cyclophosphamide, it can lead to other kinds of cancers, and the most important side effect of cyclophosphamide is that it can cause sterility and it can cause damage to the bladder, which is known as hemorrhagic cystitis. And that is why when cyclophosphamide is given to patients, we usually give Mesna. Mesna, the full form is mercaptosulfonic acid. So we hydrate the patient with Mesna so that the toxic metabolites of cyclophosphamide get eliminated without damaging the bladder. Carbimazole is actually a drug which is used for hyperthyroidism. We have methimazole, we have carbimazole. And clopidogrel, you know very well, it is a antiplatelet agent. There is one benefit of clopidogrel versus aspirin. Aspirin, you know very well that it is a prostaglandin blocker. It acts on the COX pathway. So when the COX pathway is inhibited, the LOX pathway, that is the lipoxygenase pathway, gets activated. And you know very well what comes from the lipoxygenase pathway, it is leukotrienes. And that is why aspirin should never be used in patients with asthma and COPD, because leukotrienes are inflammatory mediators which are responsible for inflammatory changes in asthma and COPD. That is why we use montelukast. Montelukast is a leukotriene. But clopidogrel, the benefit is it is an ADP blocker, adenosine diphosphate blocker. It has nothing to do with the arachidonic acid pathway. And that is why clopidogrel can be safely used in patients who are also suffering from asthma or COPD. And then the last is sulfasalazine. Sulfasalazine is actually a sulfonamide antibiotic. And sulfasalazine is also used in the treatment of ulcerative colitis. So that is about the names of prodrugs. So instead of simply saying the name of the medicines, I'm also telling you about some interesting things that I find on the way. So that is the intention of this presentation, not just to tell you this, but whatever practical catch points that I can gather from here, I will tell you. Now we come to microsomal enzyme inducers. So to remember the name of drug or substances that are enzyme inducers, you can remember the code GPRS cell 4. G stands for griseofulvin, which is an antifungal. It is not very much used nowadays because of its range of side effects. P stands for phenytoin. Phenytoin, you know very well. It is a sodium channel blocker or inhibition stabilizer of sodium channels. It is used in epilepsy. It has a wide range of side effects, including injection site reactions. It can cause megaloblastic anemia. It can cause hyperglycemia, diabetes mellitus. It can also lead to osteoporosis because it reduces the level of calcium. And it can cause gum hypertrophy. So bleeding of the gums can also happen. So that is why phenytoin is not very commonly used. It is still used in many areas. We usually focus on fosphenytoin. The side effects are comparatively less. R stands for rifampin. It is also known as rifampicin. Rifampin, you know very well, it's a very powerful enzyme inducer. That is why most of the medicines, if you are giving with rifampin, we have to be very careful. There is a huge risk of interactions with rifampin. S stands for smoking. And that is why whenever you take any medication, you are always advised to avoid smoking at the same time or at least near to that time, because nicotine may aggravate the metabolism of most of the medications. So a situation may come where the plasma drug concentration may get reduced unless and until it is a prodrug. C stands for carbamazepine. Carbamazepine is also an anti-epileptic. It also has its own range of side effects. Carbamazepine usually causes Stevens-Johnson syndrome, and at the same time, it causes a huge range of sedation. Means it causes sedation to a very high level. And P stands for phenobarbital. Phenobarbital, you know very well, it's a barbiturate, which is used in the treatment of epilepsy. And in children, it is used in the treatment of neonatal jaundice. So sodium phenobarbital we use in neonatal jaundice because it is a hepatic enzyme inducer. So it is good for improving the functional capacity of liver. So that we can use in the treatment of neonatal jaundice or hyperbilirubinemia or jaundice in children. Then we come to microsomal enzyme inhibitors. So to remember the name of drugs that cause enzyme inhibition, you can remember the code vitamin K cannot cause enzyme inhibition. So vitamin V stands for valproate. Valproic acid, there are a lot of things that I wish to say. Valproic acid, if it is used in females who are already suffering from hypothyroidism and they are suffering from menstrual problems or periods associated issue, valproic acid is dangerous for them because it can precipitate PCOD. Valproic acid increases the level of ammonia in your body. So if you are a person who is suffering from liver issue or liver cirrhosis, this medicine can lead you to hepatic encephalopathy. Valproic acid, if it is used in children below the age of 3 years or 2 years, it can lead to life-threatening pancreatitis. And it also causes hair loss, hepatotoxicity, and many other issues. But valproic acid is known as the king of anti-epileptics because it shows a lot of mechanism of actions which most of the other medications do. Because it increases the level of GABA, it is a sodium channel blocker, and it is also a calcium channel blocker. So it is good, but it has its own range of side effects. Ketoconazole, you know very well that nowadays all the other azole antifungals we use parenterally or orally, but ketoconazole we cannot. Because if you look at the mechanism of action of azole antifungals, they usually block the cytochrome P enzyme in the fungal system, and as a result of which it kills the fungus. But the problem of ketoconazole is that it also inhibits the cytochrome P450 enzyme system in the liver. So as a result of which it can cause serious hepatotoxicity and definitely a lot of drug interactions with other medications. So that is why ketoconazole we do not use systemically. We usually use it in the form of 1% or 2% something kind of shampoos in the treatment of fungal, dandruff and all this kind of issues. C stands for cimetidine. Cimetidine is actually a H2 receptor blocker, histamine type 2 receptor blocker. So it is the same class of ranitidine and all those molecules. Cimetidine is not used nowadays because it causes sexual dysfunction and a load of other side effects. So cimetidine is not very common. The next C stands for ciprofloxacin. Ciprofloxacin is a fluoroquinolone. So fluoroquinolones, usually the interesting thing is that their side effects are usually related to the heart and the muscle. So they can cause tendinitis. So you can have abnormal muscle pain. That is why if anybody is on fluoroquinolones for long term, now you will ask me who will take a fluoroquinolone for long term. For example, you are suffering from tuberculosis and levofloxacin is in your treatment regimen as part of DOTS therapy or RNTCP guideline. So in that condition, you will be taking it for a long time. So if a patient is experiencing unexplained muscle pain, they should report to the physician or the pharmacist. Fluoroquinolones also cause QT interval prolongation, which can lead to torsedus de points, which is a life-threatening form of arrhythmia. As a result of which, patients are also advised if they experience palpitations or anything like that, they should report to the physician or pharmacist. But it's not always necessary that it will happen with ciprofloxacin. It usually happens with higher agents like moxifloxacin, etc. Enzyme E, that is erythromycin. Erythromycin is a macrolide antibiotic. A very interesting feature is that if you are using erythromycin estolate, I think I remember it correct. If that is used in pediatrics, it can cause pancreatitis, liver-related issues. And erythromycin, there is a very interesting thing about macrolide antibiotics. They are motilin receptor agonist. Now you will ask me what is motilin. Motilin means, you can remember microbiology, motility. We have cilia and flagella on the surface of organisms. They are motility agents, which helps in movement. So motilin receptors are there in our stomach, which actually help in movement or gastric GI transit. What does macrolide antibiotics do? They increase the motilin receptor activity. So what happens is, if gastric transit happens very fast, you may have studied this in biopharmaceutics, if gastric transit happens very fast, it results in diarrhea. Because the food, the contents, stomach contents will be transiting very fast, moving very fast. So that leads to diarrhea. And that is the reason why macrolide antibiotics usually cause diarrhea. It is not very commonly seen with azithromycin, but it is usually seen with others. So this is one interesting thing about macrolides. And another thing is that they usually cause QT interval prolongation as well. And if you are using in very high doses, they may cause ototoxicity, but it is usually reversible in nature. That is, if you stop the medication, then it will come back to normal. Unlike aminoglycosides, if it causes ototoxicity, then it is very hard for coming back to normal. Then we come to inhibition, and that is isoniazid. So that's it for part 1 of this drug mnemonics. I have explained some interesting things about a lot of medicines that we have discussed till now. Tomorrow again I'll be coming back with the next part of this series. We'll be talking about interesting things of other molecules also, and lot of other mnemonics as well. If you support my efforts, then please do subscribe and share to maximum people, because as I always say, knowledge is power, and knowledge shared is knowledge doubled. Thank you so much for viewing this, and please do note down a lot of things that I have said. If it is of use to your knowledge purpose, then definitely do note it. And if you want this presentation, please do contact me. You can contact me at LinkedIn, and you can comment in the comment section. But it will be better if you contact me at LinkedIn. Then definitely I'll send you this presentation as well. So thank you so much. Until tomorrow, it's goodbye.